Let's start with the definition that you fix. We have to define what we're talking about. The first most important one is
backgrounds that are some of the
to define a small minority that will actively try to make any situation more complicated than it needs to be. I think we could all agree with that. Usually for the purpose.
We actually have a few of them we have to do for the afternoon sessions.
We tend to love naming and defining things. We even have a glossary of prosthodontic terms.
Yeah, there it is.
It's filled on the boards. You're supposed to know that it's like the GPT 7 or 8 or whatever we're up to. And then finally, Sigmund Goldberg. So that's a prosthodontist. But let's start with the outline. Just the fixed prosthodontist.
We're going ahead.
And this is the prosthesis that when a patient comes to you and thinks their teeth are failing, this is what they would do. When they say, just take my teeth out and give me a cancer. Take my teeth out. I don't want to deal with my teeth in it. Now, if you can have that, that's awesome. And this is a typical situation. Patient had failing dentition.
We got a few of them that we have to convert over. We do.
And we end up with a restoration.
There's a few presentations that are in Keynote that we have to convert over.
It's true, you're never going to really get it again like we did before, but as we all know.
I agree with you. So I'm just a contract out.
Here's been updated. Here's been updated. We're still communicating.
This is where we're playing a little bit with sculpting.
I got you. I understand. Yeah.
So
I'm not taking it from you.
the fixed restoration of clear presentation was like only the anatomical.
Is that the keynote laptop?
So that's the idea. Now,
The
you see
date specifically.
they still look like teeth.
We just went through it. That's it.
Okay, and so the difficult characteristics of standard when we started with a
Yeah, I know.
dentate patient, usually it's a caries patient.
But I was trying to see if it was in the notes. We can find it.
Transitioning, usually we're gonna keep some teeth, we're gonna transition to implants. Occasionally it's gonna be a low situation, but usually we're gonna have big teeth present because that was maintaining the alveolar bone.
It's situated.
Usually a common fixed restoration, it's allowed them to do vision.
Once again, I do appreciate your patience. Thank you so much.
Is that the same as if a pillow between two central incisors your natural teeth? No, it's a longer contact point, it sources the bone, but we have some shaping. All right, and here's a difficulty in a small thing or large, but we can shape the tissue, even though when you think about the bone under there, it's flat, there's no scallop of bone anymore.
Maybe it's
By
in
using
his
selective
laptop.
Pressure and provisionalization.
Because I don't see it here.
Then we got the this is a fixed restoration, when it appears to restore the anatomical crown, and the portion goes into the natural tooth, and they tend to look like natural teeth with periodontal boneless. Sometimes referred to these as banana teeth, because they kind of just look like these curved bananas. And, you know, that has its problem, but if you think about it, in most cases, it's the smile line that's going to dictate whether or not this is acceptable. And the reality is we porcelain and optimal. And we have technicians who are really good with fake porcelain. But if they avoid fake porcelain, that just makes my life easier. I mean, fake porcelain requires a whole different level of artistry that doing inside the ledge translucent requires. I mean, you can pick a gingival shade from the shade pen, but that's not really what the gingiva has to look like. And I'll show you an example next of some really nice fake porcelain work. But it's not easy. It's also not cheap. It's going to add expense to it. So in situations like this, even if I do have to have teeth that maybe don't look 100% natural in a retracted picture like this, but the smile line allows for it, FP2 is often good. Okay, and here's an example of one. This is my 98-year-old. I'm going to show you his whole treatment in a minute, but also look at how long that is. You think this guy has a high smile line? No way. You can barely see his maxillary anterior. All right, so works well with low smile line. If there's no need to show the pillow, it's great. Inside on the braziers are really what make this look like natural teeth. And in fact, this is a PMMA conditional. When I looked at it, I said, I don't like those incisal braziers. I want to open those up a little more. But that's easy to do at the PMMA level. Okay, saves us the big porcelain headaches. All right, the FP3. Now this is where it gets a little trickier. And this is where having a great technician is really useful. If you look at the big porcelain we have on here, this guy was an artist. He really did a great job helping match this gingiva. So this is a fixed restoration that appears to replace the natural teeth crowns and has pink-colored porcelain restorative material to replace a portion of the soft tissues. Okay, so these ones are great, but they're difficult. And the real challenge in these FP3s, and it's a bit of a judgment call, is where does the smile line interface with the prosthesis? Because if the patient smiles higher than the margin of that prosthesis, now you're going to see that interface. And so you have to really be careful and try to figure out, do I need to reduce bone? Or do I want to keep the bone where it is in order to have a proper interface? Now, in her situation here, you can see it, this isn't quite her highest smile line, but she wasn't able to bring her lip high up enough that we could see the interface. So here, our pink porcelain, white porcelain look natural. But that's the real trick with the FP3s. So careful pre-surgery and you may need to modify restoration by surgery. Sometimes we extract some teeth, we get more resorption than we planned, or we find that the plane is different. So we always go to PMMA before we go to final restoration. Because PMMA, very easy to modify, very easy to add and subtract, figure out where we need to be. And the take a little denture repair kink and paint it on and see what it looks. That's really easy to do. We don't have to do that once we've gotten all of it.
I mean, yeah.
Okay, and now we've got the fixed removable, because eventually you're gonna reach a point where there's so much pink and white tissue missing that we have to replace it with a removable prosthesis. Now, sometimes this removable prosthesis is also dictated by the number of implants you can get. Right, I mean, if we can only get 2 implants in the mandible, we're still not gonna do a fixed restoration. Now, according to Paul Champion, theoretically, we could do a full arch on 2 implants, but you Paul, it is theoretically possible, but 2 is not enough. So sometimes that gets taken. So with fixed removable, we basically have 2 choices here, and this was actually alluded to in one of the earlier talks. We can have the fixed bar or substructure, which remains infinitely, and then a removable prosthesis as a superstructure over it, such as a spark erosion or a bar overbend. Personally, I don't love that because I find that most patients, first of all, they've also got a few, not sure why. They think they're really going to clean well under that bar. Most do. Some do, most don't. So I don't love having a fixed bar. If you see the lower example here, having it located, much easier for patients to keep this clean, takes the prosthesis out. You can kind of convince them that I thought it wasn't made of gold, I should watch them. So, I paid a lot of money.
Oh, you see them in those.
So they do tend to rush them a little bit better than people's bar. Personal preference, but I do find in general hygiene is better over that. And if you've heard all about plaque and bacteria and all this.
I think I can correct it from here too.
So the decision process really goes, where's the current bone level? Where's the predicted post-surgical bone level? This is trying to make sure we don't show that prosthesis interface. Just briefly allude to the stackable guides we have at sequence and some others here. These stackable guides allow you to do some of these things, but what I found is, and you just mentioned about comprehensive surgery, I find stackable guides and they serve a purpose. I think they really help with general dentists restoring more than they help the surgeon doing the surgery. I think a lot of surgeons don't really like the stackable guide system, but they do it because it enables their GP or someone else to restore it a little bit easier. But I don't think still do that. So where will the natural tissue and prosthetic space fall? And the lip line is really a key part of it. We're trying to figure out what the lip line is. The face standing and all those things we heard about before we're going to talk about. That allows you to know where these things are going to be. So there's a lot of and again, as I said, can we place another face? Okay. So here's an example. This patient unfortunately had a full mouth of implants at one point, and one by one, or 2 by 2, they all started to fail. He lost all of the implants in the maxilla. He ended up with a maxillary denture, and he started to lose implants in the mandible. And he really, really wanted something fixed in the mandible. And so I made him a fixed provisional in the mandible on those existing implants. But he had food impaction problems.
Yeah,
problems. The reality is we're losing so much tissue here that you just can't do it. And you really needed an overtime. And when you look at this measurement, I mean, you look at the size of the mandibular teeth, all those times, we're talking over 20 millimeters there. That's too much.
Where you have it?
And sometimes you just have to explain to the patient that we can't do a fixed restoration. Okay, and this is a treatment done by one of my residents in prohibition. And this is a patient showing really the importance of lip support and helping us figure out where these teeth have to be, and the importance of, I think, dentures in aesthetic and implant dentistry. A lot of people say, oh, I don't do dentures, I'm an implant.
Oh, right here.
Well, you can't make a good complete denture. then you don't really understand aesthetics, because here we're replacing pink and white. We need to know what the size of lenses are, we need to know what the lines are, we need to know all the stuff of denture aesthetics to do good implants. So it always frustrates me when people are like, I don't do dentures. Well, and you don't do big implant cases, or you're not doing denture at some point along the way. So here you can see the lip support with and without the dentures. This was his existing denture, but we evaluated it and we said, well, we're gonna have to show some pink and white. And in his case, we decided that the overdenture was really the best way to go. And JB made a beautiful set of overdentures, cast metal reinforcement. I know Avident is here and they can talk to you all about it. This is not an Avident one per se, but titanium reinforced overdentures like these are great. When we could do 4 implants in the maxilla and have an open palate, patients really love that. It feels a lot less like a denture to them than your typical denture. And you can see, we've just got a ton of tissue that we're replacing. We have no choice but to do removable in a situation like this. Okay. All right, so let's meet my 97. So age alone also is not a contraindication for dental implant surgery, as many of you know. I've done implants on many nonagenarians, and they can be very successful. There are certain considerations as far as time in the chair and things like that that we want to keep an eye on, but it's certainly doable. And so, as I said, he came to me, and this is what was left. He had 5 teeth in the maxillary anterior, some broken posterior teeth, and we decided we were going to basically just at the time, I made impressions because I didn't even have the scanner at the time. There was only one in our office, and that day he was there, and I didn't want to let him go. So I made an impression, scanned those in, and we did a digital design. And I'm not going through all the details, but we checked the midline, we checked the inside ledge position, all the kind of things that we knew what we needed. And from that digital design, we could design a full arch temporary that we would use for an immediate load situation. We then go ahead and mill that. And then we do all our digital planning, make ourselves up a guide. And in this case, I was able to keep a few of those anterior teeth to hold my guide. Okay, the fully mucosal supported guides are the problem, and that's where things like end sequence and these stackable guides came in, because when you seat a guide solely on soft tissue, you have inaccuracies. I'm going to show you that in the second treatment. But in this case, we're able to keep a few anterior teeth. We're able to figure out where we can put our implants. We could theoretically have done tilted implants, but I have enough AP spread just staying in front of the sinus wall to get 5 implants in here. And so we go ahead. Works. There we go. We're going to keep 3 of the teeth, because 2 of those teeth were in sites I wanted to place implants. And we check our seating of our guide, seats on those teeth, plus we have palatal support for that guide, so we know we have a really good seat. And we're going to go ahead, place our 5 implants, and then once we do that, we'll move those 3 remaining teeth, and then we can do our immediate load. Okay, and here it is. We were actually able to load 4 out of the 5 implants. Now look at his lip. When I show you the picture of his whole face, that's only like half of his upper lip right there. We've got a lot of coverage there. Okay, so jump ahead. Now we've got our implants integrated. This is 3 months later. We then use our Trio Central scanner along with other things. We do a 3D printed model. We verify that using the temporary verification jig. If it doesn't verify, now we can cut that and modify our cast so we know that it's accurate. We want to know that it's accurate before we start milling zirconia. Right? I also do a verification jig in most cases. I like to have a physical jig just to check and make sure that that model is accurate. So when they're fitting the zirconia on that model, I'm confident that that will then just transfer right to the time. So that may be overkill, but I like to do belt and suspenders there. Now here's an interesting thing. We mentioned mill. You saw how small that was. We actually needed this puck that was high enough in order to mill this out of zirconia, because your typical 30 millimeter or 40 millimeter puck was not going to cut it, given how high his lip was here. But we were able to get one. We were able to mill it. Oh, there we go. So first we mill it in PMMA, again, to try that in, verify the fit, also verify aesthetics, phonetics, all that kind of thing. There's that. And then Once we're happy with it, we convert that to zirconia. And then in this case, we put some pink porcelain on it, simply more as an experiment. This is something we did a while ago. This was one of the first zirconias we milled in office. And cosmetically, it's not the greatest result you've ever seen, but it was adequate. And you'll see how much of this you actually see in the patient's mouth. It's almost a moot point. This is more a functional restoration for him than it was aesthetic. And so here he is. If we have the volume here, I'm going to start the video. Hold on. Can we go back one? Is the video not going to play? May not play. We're not going to waste too much time on this. All right.
Been about a year since Dr. Goldin finished the work he was doing
He had a stroke.
on me. And everything has been totally comfortable. No pain, no problem. And I'm very pleased.
See that upper
I did
lip?
everything. Things with bones like lamb chops that you have to gnaw it off, or ribs. And I find that I'm comfortable all through. It's back the way they were during the earlier years of my life. I've got a youthful mouth, at least. That's good enough for me.
Good enough for me. So 98 years, he got through the procedure, and now he's able to eat and chew and be with his family. And I mean, that's really why we do what we do, to be able to help people like that and do it in the minimal number of visits. You know, he had an immediate load, so he had a temporary right away. After healing, we converted that to zirconia. Really about 4 or 5 visits total, you know, separated over time. And I agree too, you like to have a little bit of healing, let those tissues heal before you go to a final restoration. But he was great. Unfortunately, he is no longer with us, but he did well. And I mean, this was finished almost 5 years ago. But he did great, and he was a great patient. He really appreciated what we were doing. So we don't need to hear it again. Try to get it to play once. Now it plays twice. Can we advance? There we go. Okay. So now, second patient. This is the mother of the dental student. Okay? And this is how she presented to my office. Let's see if we can get that video to play, because this is an important one. There we go.
Okay, just close up and down.
So here's checking her occlusion. So if you could tell me what the vertical dimension is and the centric relation, that'd be awesome, because that would have helped me out. So where do you start on a patient like this, right? The good news is the nicest, sweetest, most appreciative woman you've ever met in your life. And she just said, my son tells me that you're the doctor who can fix this, and I don't want dentures for the rest of my life. What can we do? So obviously we've got to do some homework. We've got to do some radiographs. We have to do some scans. We have to do some interocclusal records. We need to figure out what is her vertical dimension? What is her centric relation? And the reality is, although some of that still has to be done in an analog fashion, some of that can be done and then combined into the digital world. The one thing we really can't do fully digitally right now is record-based registrations here, because in this case, she has no vertical stop. So I had to make wax rims and get a centric relation record and a vertical dimension. But from that point on, we can pretty much go digital. Okay, so here's the panoramic. Obviously, you can all appreciate what's going on there. I mean, would I like to do immediate load in this situation? Sure, I'd love to. But the reality is these teeth had so much mobility. There was so much infection in the area. I really didn't feel comfortable placing implants into some of these, even some of these immediate sockets. You've got areas on almost all of them. You know, it just didn't seem appropriate. And this is the situation where you really just have to go to immediate dentures. Didn't want to, but it's almost unavoidable in this case. You could place implants and do it, but I don't think you'd end up with a great result if you did.
Okay, so now what we've done is we have our intraoral scan, and obviously the teeth in blue here are her existing dentition, and the white is starting to figure out where we want to be. And there was one miracle that happened in this case, and that miracle was that tooth number 8 is lined up perfectly at the midline. I don't know how that managed to stay that way, but you know, we use the floss, we look at the patient's facial aesthetics, we do facial analysis, and the midline is actually right where that central incisor number 8 is supposed to be. So that gave us a good starting point, and from there we can start our digital design. And then what I do is, using those wax rims in order to get our centric relation and vertical dimension, we combine that with the facial photos, facial scans, all the stuff you saw before, and run this video. You can see all the different layers that we can see in the patient here. This is using exocad. You can see the rims, capturing the vertical dimension, getting the centric relation record, and combining all of this data together so that we can figure out where our incisal edge position is and where our restorations need to be. And so from this, we can actually digitally make up a set of immediate dentures. And this is a completely milled denture. It's milled out of a single block of acrylic, and then the pink is just pink stain and coloring that we added onto it for aesthetics. And this is a quick and easy way to do this. This could be 3D printed or 3D or milled, actually. There was some discussion about the two technologies. Can be done either way. This particular one was 3D printed, but strength was not a super concern at this point. These were full dentures. There's nothing under them, no attachments, no holes in them at this point, and they work quite well. And sort of hearkening back to what I said before, denture aesthetics are the most important part here. This is going to dictate where our incisal edge position needs to be, and all of that then dictates where the implant position needs to be. As soon as we know our 2 central incisors or maybe our anterior 6 teeth, everything else is going to fall into place. And so now we can take this information. We have our midline, we have our incisal edge position, we have our smile line, and phonetics will be checked here too. This is right when they were delivered. And now we can start to get an idea of whether this fits the things we're looking for in the patient's smile. And we can make adjustments. This is acrylic, easy to add to, easy to subtract from. And now at least we've got some sort of baseline to try to figure out where things go. And I'm not going to go through all the details here, but we can basically now set up to do a full mouth guided surgery. And so we're going to use a dual scan technique where we scan the denture, we scan the patient's bone, we can figure out where we want our implants. Yes, all on 4 is possible. I prefer all on 6, but to each their own. And you know, we can also figure out at this time, do we need any angulated abutments? Can we use straight abutments so that I can get to that multi-unit abutment stage as quickly as possible? Because once I get to multi-units, I'm happy. Everything's easy. But you need to make sure you choose the right abutments, choose the right positioning and all that. So we're able to do all that. I'm not going to go into the details of it, but we can do that. We can then convert these into surgical guides. I'm a really big fan of the Versa surgical guided system. I don't know if any of you are familiar with that, but the Versa burrs are designed for bone osteodensification. They actually run in reverse. And they're great, especially when you have thin, not great bone. As you can imagine, her bone was not great. There were infections everywhere. When I went to extract those teeth, I would put the elevator in and it was just like mush around those teeth. And so I knew she didn't have good quality bone. So I really wanted to densify that bone if possible without lots of additional bone grafting. So using the Versa system was really useful in this case to get good primary stability. Remember, we did not immediately load here. We're using immediate dentures, but I still want good primary stability of those implants because I'm placing 12 implants. The fewer of them that fail, the better. So osteodensification is nice. So we got a 2mm twist drill guide on one side, and then I have the Versa guide on the other. I like to start with the 2mm twist just simply to make sure that my sites are marked properly. Sometimes there's complications at that point. It allows you to stop, open a flap, figure out what's going on, rather than, as I said before, doing these blind surgeries and just assuming everything's going to be okay. All right, so skipping ahead. Now we've got 12 implants in, all in good positions, good primary stability, and she's just going to wear the immediate dentures now for 3 months while these osseointegrate. There we go. Okay, immediate dentures in place. She wears these, she's happy. So now we get to stage 2 and denture conversion. Now I also know there's a lot of products out there as far as denture conversions go. I'm a prosthodontist. I'm a little young to be old school, but I'm kind of old school. I prefer to just cut holes in my denture and attach them and not go through all these crazy conversion processes. But whatever you want to do, it doesn't really matter as long as you achieve a proper end. There's a lot of discussion, especially with my residents, incision versus punch. You know, they want to know, oh, can I just do a punch? Everybody wants to do a punch. Well, any of the periodontists and oral surgeons around here, the most upsetting thing in the world is watching keratinized tissue go in the garbage. So I really do tend to go more towards incision than punch, unless I've got just so much keratinized tissue and I can see where it is. You know, the advantage of the punch that day versus doing a very tiny incision, which sometimes can be done without even suturing. Usually I like to see where I am and be able to push more tissue off into the buccal to make sure we've got good keratinized tissue. Choosing the abutments, hopefully same as planned. By the time you get to stage 2, you say, okay, on 7 and 10, I have 15-degree angled abutments. I got them in my drawer here, ready to go. And hopefully they're the same as what you planned. Not always, but sometimes. And this is where we can start to evaluate. Once we do our conversion, I'm going to start cutting that denture back. Do I cut away all the pink? And if I do, that tells me that I'm probably more like an FP1. Or once I attach it and round my edges and cut my flanges back, I still have a lot of pink. Okay, maybe I'm more FP3. Maybe I even need to go to removable, but in most cases, we can still do it fixed. And this is when I get happy. If I can get to my multi-unit abutment level and that's where I want to be, now this case is fairly straightforward from a prosthetic standpoint. All right, so here we are. So now we did stage 2. Yes, I did an incision. I want my keratinized tissue. And in fact, in this case, what happened was I was a little off in the anterior and I had to use my angled abutments in the anterior. So I actually did not attach the 2 lateral incisors at this point. But again, all on 4 is enough. It is adequate, but I eventually will get this to all on 6, make our holes in our denture, attach it, trim the flanges, cut out the palate. Now we're starting to transition this patient to something that feels a lot more like a fixed prosthesis rather than having to be in these immediate dentures. Again, I'd love to never give a patient an immediate denture, but in a situation like this, there's almost no choice because I think the risk of putting immediate implants in those infected tooth sites is just not worth the risk. Okay, the converted dentures. And then now you can see the tissue starting to heal under there as we've polished them and adjusted them. Now we've got all the abutments in. In the mandible, able to use straight abutments in every position because our planning really was adequate. In the maxilla, we had a little bit of problem with thin bone where we couldn't get the implant exactly where we wanted. But the angled abutments help us fix that. Okay, so now we mill our PMMA provisionals. These act A as provisionals, but B as verification jigs as well. Make sure that all of our records are accurate. It's in essence a verification jig, and then the patient can wear that, and it allows us to evaluate. Now again, this is sort of an FP2, right? Kind of looks like periodontally involved teeth. In this case, again, very low smile line. So if I can save myself the hassle of pink porcelain here, I'm going to. It makes it harder for the patient to clean around. It's harder for the tissue to heal well. So in this case, these are the PMMA try-in. She's been wearing them now for a couple of weeks. She's been happy with it. We're about to convert this to zirconia. But you can see, we can evaluate the aesthetics. We can evaluate her lip line, her smile line, and all that. And she's very happy having a fixed restoration. This was a first version on your left, and then a second version on the right, where I just basically carved and modified the teeth a little bit, which is what you can do in PMMA. So it's a very easy way to be able to get the patient, comfortable with the provisional. So off to our zirconia mills in the lab, and that's actually where this case is right now, having the zirconia milled, and we should be able to deliver that probably in the next week or so. So just remembering where she started, where she is now with her PMMA provisional, which is very much what her zirconia will look like. Any minute now. It's just replaying the video to remind you where she started. You really have almost no choice but immediate dentures here. Again, could do immediate placement, but a lot of infection, not my first choice. All right. So in summary, I'll try to keep us on time here, Michael, catch up. FP1, FP2, FP3 are removable. You really, I think the most important thing to think about is smile line. You have to figure out where is that interface between prosthesis and tissue going to be. And if it's going to fall right on that smile line, you're going to have an aesthetic failure. It may be fine prosthetically where they can function and all that, but if you see that interface, that's not what they want. Patients want the FP1. That's their goal. They want to have something that's going to look and feel like their teeth and not have to think about pink porcelain. They don't want that. Sometimes it's dictated by anatomy. I mean, some people have a very high smile line. Some people have a long lip, a long philtrum. It hides things better. That allows us to avoid the pink porcelain as well. If we can have a contact point in a place that looks natural without doing all this additional surgery, that's great. Tissue prosthesis interface, as we've alluded to, and denture aesthetics. Not to harp on that again, but that to me is the key to understanding where the implants have to go. Because if you don't know where the incisal edge of those teeth are going to be, then you can't necessarily get the implants in the right position. So, you know, a lot of people still like to poo-poo the denture, but the denture is so important for understanding implant dentistry as well. So I hope I caught us up in time here. Thank you for your attention. And I don't know if we take any questions now, but thank you.